All right, let's dive straight into this clinical explainer. We're doing a rapid-fire board review of high-yield pediatric presentations, focusing purely on test day decision logic. No fluff. We're jumping right into the algorithms you need to absolutely crush your Step 2 CK.
Here is our patient list for today's ward rounds. We've organized this chronologically by age to help you build a bulletproof mental framework. We'll hit the neonatal ward and NICU, evaluate the crying infant, cover pediatric GI and surgery, review infant safety and risks, and wrap up with adolescent health and puberty. Let's get to work.
Section 1, the neonatal ward and NICU. We're kicking off morning rounds with those classic newborn presentations that you absolutely have to be able to tell apart in a split second.
Okay, here's a classic attending pimp question for you. What's the diagnosis for a newborn who has a fluctuant scalp swelling that crosses the suture lines?
When you're evaluating a post-delivery scalp swelling, visualizing the exact anatomical boundaries is literally the only way to keep them straight on test day.
The absolute make or break detail here is the periosteum. A cephalohematoma is bleeding trapped underneath the periosteum, so it does not cross suture lines. Caput succedaneum, on the other hand, is just superficial subcutaneous edema. Since it's above the periosteum, it crosses those sutures easily. Just remember, a caput wears like a cap over the whole head.
But you can never, ever forget the ultimate red flag, the subgaleal hemorrhage. Like a caput, it crosses suture lines, but this is actual bleeding between the periosteum and the galea aponeurotica. It's highly fluctuant, it expands over a few days, and it can cause massive, life-threatening blood loss. You're looking for tachycardia and severe pallor. Do not miss this.
Moving to the next bed, we have a 1-week-old newborn girl presenting with bloody vaginal discharge. So, what's your next best step? Parents are understandably terrified when they see this, but as the physician, you've got to know the underlying physiology. Take a breath, because this is just simple neonatal withdrawal bleeding. It's a completely normal consequence of maternal estrogen withdrawal after birth. Your only intervention here is pure reassurance. That drop in maternal estrogen causes harmless endometrial sloughing, and it clears up entirely on its own within a few days. Moving on to Section 2, evaluating the crying infant. We're stepping into the outpatient clinic to tackle one of the most stressful chief complaints out there, the inconsolably crying baby. Triage is critical here. You have to rapidly differentiate benign infantile colic, where you have a totally healthy infant crying for more than 3 hours a day who just needs some soothing, from true surgical emergencies like intussusception. With intussusception, you're looking for episodic irritability, legs drawn right up to the abdomen, and bilious emesis. And hey, always screen for hidden trauma. Think hair tourniquets on the toes or a hard-to-see corneal abrasion. All right, here is your next clinical scenario. An infant presents with poor feeding, a bulging anterior fontanelle, and an increasing head circumference. What is your imaging of choice? This is a massive red flag. You have to act fast, but the boards are absolutely going to try and trick you on the imaging modality based purely on the baby's exact age.
Lock in this test day heuristic. If the infant is under 6 months old, use the acoustic window of their open fontanelle to get an ultrasound. That open window is your absolute best friend. If they're over 6 months and symptomatic, you go straight to a CT scan. MRI is generally kept in reserve for stable, asymptomatic patients to spare them the unnecessary radiation.
All right, on to Section 3, Pediatric GI and Surgery. We've just been paged for a surgical consult to evaluate some acute gastrointestinal pathologies. Check out the linear, branching gas patterns visible on this X-ray. That is pneumatosis intestinalis, the absolute classic hallmark of necrotizing enterocolitis, or NEC. You're mostly going to see this in premature, very low birth weight infants, and it requires immediate, aggressive attention. Because these preemies are at an extremely high risk for lethal septic shock, you have to act instantly. Stop enteral feeds immediately, get blood cultures, then start empiric broad-spectrum antibiotics right away. You also need to initiate nasogastric decompression and IV fluids and keep a super close eye out for any signs of bowel perforation. Now, let's contrast that acute crisis with a much more common chronic outpatient issue. You really have to know how to separate functional constipation from pathologic causes like Hirschsprung disease. The big tells for pathologic issues are delayed meconium passage, narrow ribbon-like stools, and poor weight gain. Functional constipation, on the other hand, is usually just a phase triggered by toilet training or the introduction of solid foods.
That brings us to Section 4, Infant Safety and Risks. We're pivoting heavily into preventative medicine and safety risk assessments, which are massive, high-yield topics on Step 2.
Sudden infant death syndrome is the absolute leading cause of mortality in this age group. It's crucial to know that smoke exposure heavily impairs an infant's vital arousal responses. As a physician, you have to vigorously counsel families on these risk factors. That means emphasizing a firm sleep surface, avoiding prone or side sleep positions, removing all soft bedding, and ensuring zero maternal substance use or smoke exposure.
Moving on to musculoskeletal screening. During your physical exam, be on the lookout for asymmetric hip folds and an apparent femoral shortening during the Galeazzi test. That's where one knee visibly sits lower than the other when the infant is lying down with hips and knees flexed.
So how does this translate into clinical action for developmental dysplasia of the hip? It's all about the exact timeline of femoral head ossification. First, you perform the Barlow and Ortolani maneuvers. If they're positive, or if the baby has major risk factors, you check their age. Under 4 months, get a hip ultrasound, because that cartilage hasn't ossified yet. Older than 4 months, that's when you switch over to an X-ray.
Finally, we reach Section 5, Adolescent Health and Puberty. For our last set of patients, we're stepping into the adolescent clinic to untangle a complex endocrine presentation.
Here's this scenario. A 15-year-old girl comes in with no menses, but she has totally normal secondary sex characteristics. What is your absolute very first step in the workup? Remember, primary amenorrhea isn't actually diagnosed until age 15 if those secondary characteristics are present. But once they hit that threshold, you need a strict, step-by-step algorithmic approach to nail down the exact cause.
At first glance, this endocrine workup looks like a total nightmare, but it actually boils down to a few very simple branching logic paths. Mastering this flowchart removes all the guesswork and panic on test day.
Your absolute first step is always a pelvic ultrasound to confirm the presence of a uterus. If it's absent, you get a karyotype. If it is present, your immediate next step is to check FSH levels to differentiate between central and peripheral causes. If FSH is high, you're thinking Turner syndrome, so you get a karyotype. If FSH is low, you're thinking central causes, and you order a cranial MRI. As we wrap up this explainer, I want you to ask yourself, are you just memorizing disconnected pediatric facts? Are you actually building the underlying clinical decision trees that will make you an exceptional resident? Think about it. Keep refining those mental algorithms, and we'll see you on the next round.